This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I share my conversation with Luke Bongiorno, where we discuss pain and the elite athlete. In our discussion, Luke covers key concepts and assessment strategies for pain, essential questions and tests for evaluating athletes' pain, effective treatment approaches, real-world case examples of pain management, and more. Luke Bongiorno is a physical therapist and director of NOI Group since 2021, succeeding its founders David Butler and Juliet Garb. He co-founded New York Sports Medicine in New York City and specializes in pain management and sports injuries, working with professional and Olympic athletes, performing arts groups, and as a consultant for the NBA and European soccer teams. An educator since 2004, he teaches advanced manual therapy courses and has been on NOI's faculty since 2015. Luke previously joined us on episode 120 in November 2023 to discuss pain and the neuroimmune system. Check it out if you're interested. If you find our conversation informative, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who might benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Neck Care.
Treating neck impairment? Get objective neck assessments with the Neck Care system. Learn more at neckcare.com.
Hi Luke, welcome to PT Pro Talk. How are you today?
Well, thanks, Mariana. How are you?
Good. Excited to have you back, so welcome back.
Thank you. I'm excited to be back. Always enjoy our chats.
Let's just talk a little bit about yourself, your background for the ones that don't know you.
My name's Luke Bongiorno. I'm trained as a physiotherapist or physical therapist from Australia. I've spent the last 25 years, though, living primarily in New York, but working all over the States. I'm still in clinical practice, and I also am involved. I'm director of NOI Group, so I teach professional development courses and involved in creating some of the content for NOI as well. Currently, I've found myself working a lot more in professional sports, so that will, I guess, be our focus today. And that's where my focus is at the moment, sort of high performance athletes and musicians and other things.
Before we continue our conversation, I wanted to take a quick moment to tell you about a special offer from Sarah Health. Visit sarahealth.com/ptprotalk for a 90-day free trial. That's sarahealth.com/ptprotalk. Make RTM simple. Choose Sarah Health. That's sarahealth.com/ptprotalk. And now let's get back to our conversation. Great. And then for the ones that want to go back and listen to our previous episode together, episode 120 in November 2023, and we discussed pain in the neuroimmune system back then. So if you want to go back and take a listen to that. So today we're going to talk about the pain in the athlete, right, Luke? So do you want to tell us about like your project with the NBA that you've been preparing and being part of that paper?
Yeah, so, I've been working, as I mentioned, I've sort of fallen into professional sports. It wasn't my original practice. I've always worked around sports and had individual athletes, but my work started with basketball probably in around 2017, 2018. I'd sold my practice in New York and became more involved with the Players Association. And my role with them that's the union for the players, the NBA Players Association. My role was to serve as a player advocate. So when there was an issue with the team, I would come in and do an assessment and try and get better communication using my experience with a biopsychosocial approach to work with athletes. So that's how I got more involved with athletes. And what was very interesting was as I learned more and started treating more, I realized, wait a minute, while these are professional athletes, they're very, very highly paid workers' comp cases, because I would get the medical staff from the team saying, but he should be better by now. He should be healed. We've never seen this before. And I said, well, if you'd had some experience with return to work programs, this is basically a return to work program, but the stakes are a lot higher in terms of, the financial cost with these high performance athletes. So just with one individual. So that's it.
Yeah. Okay. And then I thought about doing a brief overview about the pain and some key terminology just to help people that are not familiar with it. And then we jump more to the specifics of assessment, treatment, some cases. So let's just talk briefly about a brief overview of pain and some key terminology.
Well, I think, and sorry to segue from the last question, you did ask me about the paper I'm involved in. About 4 years ago, I was asked to do it terms in because I was asked to write a paper or be involved in coordinating. It's not just me. There's, Professor Ebony Rio from Australia, and then some psychologists. It's a multidisciplinary approach. So I've been very lucky to be involved in that, in writing of that. And it's still not out, but because we're getting constant reviews. And one of the points of issue is definitions and terminology around pain, which is very misunderstood. So quite broadly, I guess, pain we now understand as a very multifactorial, complex phenomena that's a subjective experience, and it is influenced by a whole host of factors, both within the individual and our neuroimmune system and our past experiences, and also with our interactions with practitioners and the environment. That's their immediate environment within the franchise or the club or that they're working in, their workspace, and also the external environment, influence of media and other phenomena as well. So pain is really complex, and while it's hard to sort of go through every single little definition, I think we can think of it simply from a physical perspective, from a pain science, pain mechanisms perspective. There is what we traditionally know as nociceptive type pain. So that's, we have an acute injury and we have our nociceptors sending messages to the spinal cord and brain, activating our immune system, creating an inflammatory response to facilitate healing. So that's nociceptive. We also have neuroplastic pain, which is then what happens to the brain in pain and how our brain then becomes hardwired to alert us for danger. So if we go back, it's like touching a hot stove. If we see a hot stove again, we're less likely to touch it. It's a protective mechanism. The same thing happens in sport, even to the point where if they go back to a situation where they've previously gotten hurt, their brain subconsciously or consciously will create protective responses. So that's just an overview of not necessarily, we often think of biopsychosocial as psycho, like it's within their control. We know that it's a very, very highly complex interaction of an immune response, which is at a subconscious level. And that's why rehab and including different factors that address a multitude of varieties, not just your physical objective measures and data, is so important to help a player return to full health and keep them there. Because they can return to play, but then you often see so many re-injury. Why are they getting hurt so much? Oh, they're labelled as injury prone. Well, perhaps if they were educated and taught and treated a little bit more holistically, they wouldn't be. And I'm not a magician here, I'm just lucky to have gained a bit of wisdom, often through my mistakes, to learn that, you know what, it is worth considering all these
Yeah.
factors that I would have maybe brushed off when I was going through school,
Yeah. And then, so when you are assessing pain, what are some important things that you have to consider?
I'll be honest with you, and it sounds rudimentary, but first and foremost, you have to consider the human being in front of you as a human being, not, as well as their identity as an athlete. And I will try my best to learn as much about that human being as possible without getting too personal, because often if you think of in the pro sport setting, athletes by nature are naturally quite guarded. You think about it, especially the ones that have got to the highest level, they're often guarded and fearful of what's this person trying to get out of me, or what's the goal here? I'm under threat. They're putting themselves in vulnerable positions and made it to the highest possible level. So they're naturally guarded. But my job is to just ask them questions about themselves. What were you like when you were young? Like when did you decide that you wanted to become? Now, that mightn't happen exactly the first session, but as I build rapport, I think that can never, ever be undervalued and underestimated. And then asking them what they think is going on. I learned that question early on in my career by one of my instructors, and just saying, I trust you. You know your body. What do you think is going on? They may say, I have no idea. That's why I'm seeking you. I said, well, what's your gut tell you? I said, I can help you understand it and make sense of it, but I need to hear as much information. Nothing you tell me is irrelevant. So I might frame questions like that. I think just to give some practical examples of specific questions, which many might do intuitively, but I think really listening and taking that answer in, filing it, writing it down to be used at a later date. We don't have to do anything with the information that's presented, but we do need to build a really solid picture of who is this person as best we can, while respecting their boundaries.
Yeah. So you're asking just open-ended questions and giving them the space, and whatever they say, even if they feel like it's not relevant, it's important for them, right? It's important for them that that's why they're mentioning something.
Yeah, of course. And it's really just I spoke a little bit before about the environment, like positioning ourselves. And I've been very lucky. I've had the opportunity. I worked in soccer before, basketball and football and other sports, and I've gotten to meet a lot of very well-known surgeons. There was Professor Stedman who worked at Vail, and I think, what is it about these guys? That there is a small network of trust, a small circle. Now, he's since passed away, but there's a small circle of physicians that athletes will tend to gravitate toward. And we hear that the big names of sport. And one thing I've observed when watching them, because often I'll be invited in to go to their appointments with the athlete, because, to enhance communication, is just how they do ask open-ended questions, how they do position themselves, not standing over the athlete, but at their level, how they pause, their tone of voice, all of these things which we, again, might do naturally, but we might think of as motivational interviewing. They're fairly they come a bit more naturally, perhaps, to these practitioners, and it really helps to put the athlete at ease. And I think that's coupled with a genuine care and authentic kindness that's also evident with these people, to sort of send the message that, you know what, I'm here for you and I want to help you no matter what.
Yeah. And how do you assess if that pain could be related to physiological factors or psychological factors or social cultural factors?
Well, the key message here is it's all of those things. So I think it's important. And I talk about, sometimes when I start talking about kindness and being nice, I think, well, I'm losing people because that's not objective and that's not science-based, and we already know that. But I think I really emphasize that because that can sometimes be the missing ingredient. When you've got your objective data, you've got your information, just if your focus is trying to extract that data first, that's evident to the athlete. They're highly sensitive, often neurodiverse individuals that are trained to size up an opponent and win at all costs. So that's why first and foremost, I will start with the physiological, what's their objective data? An athlete doesn't want to think that they've got a mental or emotional component. They're tough. They're strong. Female, male, doesn't matter. They are strong. And I will say to them, that's why I asked, what do you think is going on? Let's look at your knee. I said, now I would like to assess the rest of your body. You're an athlete and a really good one at that. I can tell that, just you and you're tough. You'll try and work through, and your body's learned to make compensation patterns, and it's learned at a very high rate. That's what makes you gifted and what makes you who you are. Is it all right if I check out the rest of your body? I'll ask permission first. It's their body. That's their temple. And they'll often say, yeah, go for it, whatever you need to do. I said, well, you have to let me know. Don't just give me blanket permission. You don't know me yet. I said, but what I will do is I will check in with you, and I want you to pay attention to what's happening at all the other joints. I will absolutely address the knee, but I want to address it from a standpoint of when your body is less guarded. Is that okay if you let your guard down? I might need you to breathe and do some things to let some of that guard down. Your body won't let me go any further than is safe. And I'll use that language. But that way I'm setting the scene for addressing them as a person, but using their body parts. And that's how I will start. And practitioners will do that anyway. We all know that if you evaluate a knee, you'll look at what's happening at the hip and the foot. Now, again, I won't say, because in the patient's mind, their focus is on their knee. Their focus is on that meniscus, that piece of tissue. When they become hyper-focused, like any of us, when we become hyper-vigilant on something, what happens to our peripheral awareness? It reduces. So my job is to say, I will focus and I will give that an appropriate amount of attention. But what I would like for you to just sit back while we're in this space to evaluate, and you're safe. We're not doing anything. I'm not going to ask you to do anything on court or anything yet. But can we expand that awareness again and take some of the focus off without invalidating them and without showing that I'm going to actually address the knee? Your problem, you've come to me because of your knee, not because of the rest of you. But I want to just check in with the rest of you because it's part of you. Does that make sense? And that's something I've learned, and it might sound a little over the top, but I've learned through just doing my evaluation without communicating effectively that if me doing breathing exercises can't be linked by the patient to their knee, it's not going to be anywhere near as effective. And I had someone just the other day said, so what's the I thought, oh, great. He's going to do the breathing. So what does that have to do with my knee again?
Yeah, it requires like a skill to be able to educate them, explain, so they, they understand the process. Otherwise, they're not gonna,
Yeah, it just takes practice. Yeah, but that's, I mean, and I can go through. I'll let you ask me more questions on specifics because I feel like I'm giving sort of a general overview first.
No, that's fine. That's what we wanted. So like, assessment tests. So like you want to understand that pain, right? So what are some common tests that you do?
Well, I'll bring in the idea of the physiological pain. So again, I feel like I didn't fully answer your last question. But the psychological component, that is the emotional response to that pain. So how much of it is pain? I know you've got knee pain. Do you feel like you're guarding or protecting? I said one thing we know is that your body goes into a protective pattern It's almost like you've got muscles, they act as an internal brace to protect that joint. Even before you put, and then, I never thought about it like that. Muscle spasm is like a brace. I said, but we need your body to feel safe so that it will unprescribe the brace when it feels safe. So I introduced the idea of the guarding response as protection. And that allows me to do some simple tests, which I'll almost rudimentarily do on anyone, particularly lower extremity. I might do a Thomas test, which is traditionally evaluating for physical therapists or for other practitioners, the hip flexor tightness or length. Now, that can be an indicator also how much their muscles are holding on. And if you notice or have them notice perhaps the side of dysfunction, their Thomas test might be grossly more positive on that side than the non-involved side. And they'll be like, oh, wow, the hip's sitting right up. I said, well, did you hurt your hip? He said, no. I said, well, your hip's probably doing a lot more work to help you right now with your knee. So that's something that we need to sort of balance out a little bit. And that's when I might start just doing another assessment with a breath assessment and then reevaluate. And oftentimes just with some slow diaphragm breathing, that protective response is actually reduced. And I'll be like, oh, wow, my leg is much lower. I feel more relaxed. I said, good, now we can get some more objective data around your knee. Now we can get some more honest information. So I haven't mentioned at all psychological components, but I have introduced the idea of protection, and I have done objective tests, which are somewhat familiar. Then I can also feel and palpate around the knee, and they might say, oh, it actually feels a bit less sensitive now, or they'll be able to hone in on a more specific point. Does that make sense? It's just getting them almost more present and mindful as well. So that if they're like that with your assessment, you can evaluate the tissue. And I'm still a very hands-on practitioner.
Yeah.
And patients, particularly athletes, they will build trust often through physical touch when it's done safely. And because they're like, oh, wow, I didn't even know that was sore, but you found the spot. I have to use my sensitivity with my fingers to communicate to them that, all right, this is what I would consider, and just with knowledge of anatomy, this is why this area might be sensitive. I try not to give too much judgment or narrative around my findings too early, because often they'll ask, oh, what does that mean? Or I said, let's finish it first, because I don't want to give you information without being a bit more thorough. And that way you don't get lost in them hearing something that might stick in their brain and affect things later on.
Yeah. And in which point do you start maybe potentially doing like left and right judgment tests or 2-point discrimination, those type of tests?
I might do that if I notice that there's a stark difference side to side. I might do 2-point discrimination on their back, on their right side versus their left side. So I'm moving up even from the hip to the spine, and they might notice, and I'm like, oh, wow, the skin on that side, your awareness on that side, maybe your brain doesn't trust it. I don't always do left, right. Like we have the app on the because athletes tend to be very good at those things. They learn them very quickly. And there's not a lot of data to support that might be relevant, or correlate. However, it is a good tool to use to help get them thinking that the brain is more involved in pain, and the pain involves more than just their knee. And then if they do have reduced 2-point discrimination, right away I can say, right, try and feel the contact of that skin on my fingers if I put my hands on that part of their back. And I say, right, with your breath, breathe in through your nostrils and try and push with your breath, not your muscles, push your ribs into my hands. I'll be like, they might push initially, and I'll say, no. As you breathe in, feel the lungs expand and try and get that rib to move. And it cues in, and oftentimes that can just be enough to resensitize them and improve signaling. I call it their Wi-Fi signal to that side. Just use it as a metaphor. That's a tool we can use there.
Okay. And do you use any patient-reported outcome measures?
Yeah, I use, I'll use that outcome measures. Often I'll use just some of either the low extremity disability score. Sometimes with athletes, they don't like filling in those things. And they also feel like this is a test. This could be used against me. So I'll be honest, I use them, but if I'm with a team, typically they have their own testing equipment too to evaluate strength and specific objective to get objective measures, and they are very important. They give us a good baseline measure, and athletes can feel comfortable with that because they're already used to it. Sometimes before they return to sport, I'll use the psychological readiness for a return to sport, which is basically asking them questions: how much time are they thinking about their knee? And that will ascertain, because they mightn't bring it up. They'll be like, oh no. I said, do you trust your knee? Yeah. I said, is that a yeah, or is that a yeah? Do you trust it to play 35 minutes? Yeah. This is where the definitions have to be really important. Do you trust it to play 20 minutes? Do you trust it to jump? Do you trust it, and how much time are you thinking about it? And I said, right, if you're thinking about all the time, I'm still going to think about it. Well, I said, what percentage of your body does your knee represent? And they might say, well, 5%. So how much time are you thinking about it? 100%. I said, well, let's perhaps wait until you're thinking about it a little bit less. Let's think about some of the other body parts. Check in with your hips, check in with your feet. And that can be, so I'll use that tool sometimes to just use as a guide or a segue into retraining them a little bit more and really hearing their voice make their yes mean yes.
Yes.
I trust it, because that's very powerful.
That's what I wanted to ask you, like now from like a treatment perspective, like you're giving some examples of like things that we can do, like education, reassurance. Like, so what are some things that you think are important to consider that we should be thinking about using with the athlete?
I think what's important to consider is helping them feel comfortable and safe, essentially, with what they need to do. Now, that doesn't start with just getting them on the court for basketball and just shooting and running around. That's part of it, because they're not going to feel safe unless they actually do it. But it's getting them balanced first. And balance doesn't just mean I can stand on one leg and throw a ball. Let's start by just standing on two legs and closing your eyes. And let's reduce the surface, just like you would with a falls risk assessment for someone who's elderly. And it might seem rudimentary, but I will just start there and say, right, do you feel balanced? Then I might throw some cognitive tasks, like dual task. And this is routinely done, or it's certainly done in ACL rehab and other forms of rehab, challenging the athlete by increasing cognitive load. We often think of load management in basketball as they're on a minutes restriction. So we're measuring their physical load. But what's happening with their cognitive load? What are the higher intensity minutes? We sort of think about all of these questions, and they're important factors to consider. So that's why in the rehab, introducing cognitive load, it doesn't have to be exactly the same as what they're going to experience on the court. It's just got to be challenging enough and new enough so that they can maintain their balance under pressure.
That's so interesting, the cognitive load. So would you give us like a few examples about how would you do that?
Well, yeah. Well, first of all, for those that don't understand fully, cognitive load is, again, I'm talking about highly sensitive athletes. Highly sensitive. These are world elite, one in a few hundred million. These are people that have become the best of the best and gone to the best of the best. Now, doesn't mean they're better than any other people. They might have had opportunities, and lots of factors have contributed to that. But one one thing that is evident is that they're highly sensitized. So they're highly sensitive to light, to sound, to feel. They have this touch that separates them. And there's a lot of neural circuitry. A lot of them don't want coffee. They're wired enough. Our job is to help them calm those neurons and get them to work in a coordinated fashion. So cognitive load helps to take their mind off perhaps their body and thinking and just asking them questions. So one athlete, I said, what was your favorite subject at school? He said, math. I said, great. And I'll ask him math questions. So let's get him using a different part of his brain. I was like, what's 3 times 7? As he's on a balance ball. What's 7 times 4? 28. Now, again, it's the competitive part of them. They want to get the answer right. They don't want to be wrong. Sometimes if they liked English, I might say, well, let's spell basketball backwards, or I'll get them to spell their name backwards, or get them to just think at a different level while they're balancing with their eyes closed. And they'll be like, oh, shit, it's harder. But they've got to focus and they've got to pay attention. And then I might say, right, take a breath, breathe. Imagine you're shooting a free throw. Okay, there's no time limit on the answer. Just feel like your body is calm and think logically. And it's helping them. Their bodies will self-organize. I'm not smart enough and they're not. We don't know enough in science to, it's so complex. We can't say causal and effect. We cannot say with 100% certainty. We can have ideas, but what we do know is that if we create the environment, that athlete can self-organize a little bit and reset, for lack of a better word, and that will improve their confidence. And as their confidence improves, their natural state of being also improves as well. So that's how I might do it in clinical practice. Same thing with just standing on one leg is another, and they might be moving around and say, right, your task now is to be as still as possible. Imagine there are sensor lights and you can create, if they're imaginative, you can say, right, you got to avoid all of these lights, any slight movement and they'll hear you. You create a scenario like a game. Sorry, what were you going to ask?
No, I was just thinking that's so interesting. So making them think about something different just helps to reset. I was trying to understand the logic behind.
Well, there's there's logic, and there's also the associations with basketball can be stress-inducing responses. So actually taking them out of thinking about basketball, or I'm using that as an example for basketball players, but getting them to think about different things accesses different parts of their brain, and it will light up in a different way, and that will alter the output, which is telling muscles, joints, and things to tighten or relax, and it's dispersing. It's adding variability. The other thing we know about athletes is precision. They learn to do certain movements the same way every time, which makes them brilliant at what they do. They can repeat and get the ball in every time. That same thing might mean that certain tissues become overloaded and certain tissues become stress shielded. They don't actually load evenly in the joint. And we see that with cartilage degeneration. And we know that through tendon research that appropriate loading is really important. But we can do a split squat or an exercise, but if they're just loading that same part of the tissue and that same part of the knee without loading all the other parts, are we really getting even distribution of load? And what things can we do and what cues can we give during an exercise that helps add that variability and load the knee or the ankle or the whatever joint in a more diverse and inclusive way?
Very interesting. Look, I know we have some clinical cases that are really good to bring. I think it's going to help our practical discussion on techniques and treatments and ideas to help our clinicians.
Yeah.
I know we discussed on the paper that you've been part of. One of the cases was persistent hamstring pain without acute tissue trauma on imaging, right? So they had a history of hamstring and persistent symptoms and other stressors together with that heighten the immune system, immune activity. Would you like to just discuss a little bit that case and what are some things that we can bring to our practice?
Yeah, I think persistent thinking of pain as a sensation. Pain is what we assign. It's a definition we assign to sensory information that is perceived as pain. Now, they might have hamstring tightness, but they might have torn their hamstring. I had one athlete, when I really delved into it, I said, since your first injury? He goes, no, since I was 10. I went up for a lap and I really tore my hamstring really badly. So going back to neuroimmune science, we know that he will have a higher immune cell content, for lack of a better word, just think about it, around that area to serve as protection. The way that where the hamstring is represented in the brain could have more increased immune activity if they're in a similar situation, or if their memory is like, well, my hamstring is weak, reinforcing that message.
Mm-hmm.
So how I will do that I will educate the athlete on the hamstring. They know where their hamstring is, but I might show them there are different parts, and I might add some rotation and put my finger on a specific, maybe the semimembranosus or the semitendinosus, the inside part, and say, right, I want you to move that muscle there. And then often they'll do a gross movement, because when they're injured, their level of precision, and we've found this in studies with back pain, the level of precision is actually less. That ties in with 2-point discrimination. So helping them just retraining more precisely what part of the muscle they're activating. And I often use a metaphor with them. I say, like I was saying before, when they're loading the tissues in the same way, I said, it's like you get in the car and you drive to your destination. You go the same way every time. Suddenly there's a detour. And the first time you go a new way, it's a little scary, but then you might discover that there are less cars on that road, or a better route, or a more nicer views. So as you practice the different ways, you actually expand your options, and it gives your body more room to move, literally. In different ways, and can be less stressful ultimately. So it's a lot of it involves education and then retraining that hamstring in conjunction with all the other muscles. And I'll say, right, and I'll do often a lot of isometrics. We know isometrics work well for tendon. And patient and athletes like doing isos. Now it's quite known that I want to do my isos. So now I'll be like, well, let's power up your isos with some breathing, just like a yoga practice.
Mm-hmm.
And I'll say, if I've got them in a squatting position, I might say, right, now bring your buttock lower, take a breath in, breathe out, reach your fingertips higher. So I might have them involve their upper back or different body parts.
Mm-hmm.
I'll say, right, now pay attention to your hamstring. Lift one leg, and they'll start to really feel it active. And the sustained hold helps to improve their sensory motor awareness, and they'll feel the burn. So they're actually creating a stimulus and connectivity back to that area in a healthy and safe way, which then reinforces a safety pattern there as well. And that's using a biopsychosocial but somatic approach. And this is not necessarily new things. They're just tying in concepts that we're already using in clinical practice, but under a framework that's logical and actually makes sense to the athlete.
I think that's what's challenging, because like the persistent pain, it's not like related to the tissue. So how do you approach that with like an athlete? Right, that I think that's challenging.
I say to them, I use a metaphor, and I'll say, you're running on old software. You need an upgrade. You need an
That's
upgrade. And I
good.
say, I wish I could implant a chip, and overnight you can do an upgrade. And one athlete, and he's a very high profile NBA player, said, "Yeah, I guess we take a little longer to download." Like he was aware. Now he's 32 and he's had his fair share of injuries, but using that language of like we need a software upgrade. And it's hard to get them to buy into it. But when they start to feel it, they know, yeah, I felt that one. I felt when they start to feel changes and they start to feel stability and they start to feel connection. And one guy said, "Oh, I don't know what you're doing, but I'm starting to feel how my breathing and my tissues are sort of the relationship." I said, they're connected. I said, "Well, we all know they're connected." I said, "But perhaps they haven't had the best relationship for the past 5 years since you've had these injury bouts. So would you like to improve that relationship? They're not going anywhere. They're staying married. They're all part of you unless you want them off. So would you like to work at helping that relationship?" And using, again, metaphors to just help them buy in while you're doing that experience. But I think the key with them is giving them that experiential learning without necessarily telling them. They need to have it make sense. It's not like you can just trick them. Even if they see that it's a miracle, "Oh, wow, I did that." But they'll be like, "Yeah, but I did that once, but next time I go on court, it'll be bad again." That's a whole other set of issues as positive self-talk and framing, and that's psychological intervention that can help. But I'm just giving my role as a PT that practices with a biopsychosocial approach. That's how I will sort of broach that with an athlete.
And how about like other stressors that play a role on their pain? So like how do you bring that to them?
Like the coach or the medical staff?
Maybe the athlete is the
I've said sometimes the brain is like the coach and the knees are letting, and one goes, "Hey, the knee's a little angry." I said, "Yeah, but you know what? They just let them both listen to each other and try and have dialogue so that they're not traded. You're not trading this in." Yes, there are other stressors. How do I broach that? I ask them, first of all, I do, we have the protector meter in Noi Group. Have you seen that one with the DIMS and SIMS? What are your DIMS? Danger in me, safety in me. And I'll get them to just write down some of their DIMS, and they might very directly put someone maybe on their team, one of their staff. "Oh, I don't like him. He makes me do this. He makes me do that." Because athletes are taught to follow direction. And sometimes I'm there and I'm like, "Well, he asked you. He didn't make you. He asked you." But, the athlete being non-confrontational to that authority, he doesn't want to ruffle any feathers, is just going along with it. I'm like, now they'll get to a point where they start to say, "No, I'm not doing that." But then my role is to say, why? Why don't you want to do that? Why will you do a quad test and not a calf test? "Well, I don't want to do this because I've been feeling sensitive there, so I don't want to test that out today." So I'll ask them again, just like I did at the very beginning of this interview, asking them open-ended questions of why, but in a way of curiosity rather than why, like judgment, just in a I'd like to understand. And again, I'm lucky because that level of trust with the athlete happens with time. You can't just, it's not that. It's like the old adage: you got to show them they care before they care what you know. But those are some of the ways, and then also speaking with the coaching staff and the front office staff to let them know about the environmental impact. And I went to one NBA team a few years ago and did an explain pain course, but it was the pain science needs to be messaged. And this is in the paper very clearly, not just to the athlete and not just to the medical team, but to anyone involved in that environment that can have influence. and the agents as well. Okay, because everyone can have influence. Other athletes, one athlete saying something to another athlete can have consequences of, oh, I don't feel safe speaking up again because everyone's going to think that I'm making this up, or all of these things. I think that needs to be, the messaging needs to go out at a whole level, and that's, I think, one of the reasons the paper's taken so long is because I'm like, how do we communicate that? Because just pain science being output from the brain and not a biomedical approach is new enough information. But trying to get to change a culture, that takes a lot of time.
Yeah.
And we see it. There was a team in Australia. Well, once that culture's changed, it has results. It's not just about reducing pain, it's performance. There was a team, the Richmond Football Club in Australia, and there was a book written about it when they started to create an environment of safety and openness. That team went from one of the bottom teams to winning like 3 premierships. And it's happened here. I've been involved in even just in the women's, the New York Liberty, the women's team here. Like they won the championship this year. And a lot of it was not just how they educated players, but how they educated their staff in dealing with the emotional consequences of an athlete. Because as a staff member, and I can feel for this, and I've felt it firsthand, is when you're dealing with an athlete, it's very hard. Again, by nature, they're combative. They've often learned behavioral patterns and they feel misunderstood, not heard, not listened to. And if you're working for the team, you're trying to get them to do something that they maybe don't want to do. You're seen as like the opposition, even though you're on the same team. Sometimes that is, not always. And it's challenging. And I think it's important that we as practitioners understand our own level of emotional control and how we can't blame them to say, well, you're not listening to them or they didn't do what I asked them to do. It's our job to sort of like regulate and not rush things and be aware of our own emotional responses, because it can be very frustrating.
Yeah. And
like dealing with a teenage child. I don't know if you have kids, but
yeah, and so many different factors, like, right, return to play. They might be afraid of losing their space on the team, so they don't feel maybe safe to return, and they are being pressured to return. I had one guy. He said, "Oh, I felt like I was ready, and suddenly I've got the schedule, and like, bang, there's 3 games in front of me." And I said, "Well, how about you just look at one game, take one game at a time, because especially in the NBA, it's grueling." And the travel and the lack of sleep and the changing of time zones. And people think, oh, these guys are getting paid a lot. But they're still human beings. They're young men and women that are put under a lot of stress. And there's a huge expectation for them to perform night after night. And they're criticized. It's really, I see and I feel the effect of that. That's just how it is. But at the same time, I think just acknowledging that at least before we go and fire at them. And that will allow the athlete, once they have that space to feel safe, they can perform and they can self-regulate better. They can do what they need to do for recovery and all sorts of things. I know you're pretty much out of time. Just one more question.
Yeah, sure.
So we know that some protective movement patterns also can prolong that pain, right? So do you have any strategies that you use to help them break these habits?
Yeah. So sometimes I'll give you one example. And this is a guy that had persistent foot pain. And he said, "Look, every time I push off my big toe, I notice that my hip turns in. My hip internally rotates." And it again, that's going from a precise, fine motor control to gross patterning. So I would say, right, I want you to keep the pressure through your big toe. Now actively turn your hip out. And now a lot of practitioners will do this naturally. It's just dissociating and breaking patterns at a physical level. And another thing I might suggest is just having them starting from the ground up. I'll say, right, because they might think I'm over pronating as a bad thing. I'll say, I want you to pronate, but when you pronate, go all the way, now supinate. So rather than thinking of a movement as being good or bad, get them to actually feel and get the sensation through the full range. And I say, I need to give your senses, so that we need to train them so that when you're in a game, you don't know where your foot's going to go. Or if someone pushes you a little bit more out of your comfort zone, your tissues already know that they've been there. So that can be a way to help get them to feel safer, and from a physiological perspective, help their Golgi tendon organs, their joint sensors, to be more comfortable with those certain movements. Because when they're protected, obviously there's a reduced mobility there. So focusing on that. And this is something, again, that's not new and people are doing it, but just start to think about it from a framework of, I'm actually helping them break that protective pattern and feel safer.
Okay. And just we were talking about the return to play really quick. So how do you balance those physical and psychological aspects on the decision of return to play?
I think the important thing is keeping the main thing for an athlete, the main thing. So that's their physical, they'll look at their strength factors. For a knee patient, what's your quad strength? What's the imbalance side to side? That's a very objective measure. And I think that's really important that we keep that. But we look at that as a factor. The other thing we look at is what has been their training load. And that, certainly in professional franchises, there's a lot of very good and fancy equipment that measures what they've done in practice. And then we try and factor in psychological factors. Is the cognitive load of an NBA game is going to be a lot more than practice. And with an athlete, I will generally say, because they like to control the factors in their practice and in their training, and I'll say to the athlete, so you want to go from a place of where you've got full control. I said, how much control do you have in an NBA game? I said, well, it's chaos. I said, well, why don't we start by adding in some variables that you're not aware of in your training, and get the athlete to start think, oh, okay, yeah, I need to think about this. Like, I need to surrender some control or lose some control. So that's a psychological factor, but it's playing into their return to play. The other thing is, again, just recognizing, all right, you might have had a physical load of whatever number, let's call it 350 in practice, but in the real game, it might be less than that. But all the other cognitive factors might mean that we start, when we're returning to play, at a much less than training load, and build that up. And that's why minutes restriction helps, because there's a high correlation between minutes played and physical load. But we're also helping the athlete not to go soft, to help. We can say, right, you can go at a high level of intensity because your minutes are restricted. Because often they'll think if their minutes restricted, the level of intensity that they play might be a little bit less too. Does that make sense? And they're holding back. But that's not necessarily getting them back to their peak level. So that's why balancing those two factors. And I think this is where working with teams, and I'm an independent contractor practitioner, but it's really important that any practitioner works within the team and with their staff to help to get a more comprehensive and complete approach. Because without that communication and consistent messaging, it can be harmful. Certainly not advantageous at best for the athlete.
Okay, awesome. Well, I have so many questions, but we're gonna have to wait for our next time then.
Do you want one more, or are you good?
Do a third one, Luke.
You want one more, or you?
Okay, I'll do just one more then. I'm abusing of your time now.
No, you're not. You're not. I'm offering.
It's just about like the neuroscience education, as you mentioned, that you have to prove them so they have their buying, and then they become more interested in learning. So like, how do you go about education, like pain science education with the athlete?
I'm grateful you asked that question, because it's a really common one. And one that I've struggled with, and I've had to learn different ways of doing it. And I think one of them is trying not to fire in too much information too quickly. Sometimes as I'm working on them, they'll ask me a question and I'll give them an answer. That's taking away from the physical experience of me working on their tissues or our connection in a way. So I might say, let's shelf that question and I'll answer it later for you, but that's a good question. So just ordering it. So I might give them some basis of, all right, here's what I want to do and here's why I want to do it. Is that okay? So you're getting the consent. So you're providing some basis for adopting an approach. I want to see how much your body's protecting. I want to even go up to your neck and your jaw, because when we clench, when we're protecting, I want to feel the tissues side to side. I want to be really thorough with you. You're a high value individual, and I want to do it right. So that sets the scene for, okay, there could be something in this. Then they start to feel it in their body. And that's when they start to maybe say, oh yeah, it's connected. How was this? How was that? If they're inviting that curiosity, again, shelf that. I will answer you. And then after the session, I'll come back to the answers. And then I'll ask them to teach it back to me. And then I've got some handwritten, for some of the athletes, I've got some handwritten, just 1 pages, very simple. But I said, this is now for your reference. So when it comes back, I want you to read it. And you know what? I might test you on it as well. So I really want you to understand it. You've asked me, and I give them the, teach you how to fish. And I want this to be set up for you long term. So that I'll set it up like a curriculum rather than trying to do it all higgledy-pickledy. And that's how, because that, again, if you think about it, pain neuroscience education is not about didactic learning. It's about experiential learning. And that's where that, that emotional reassurance and then the cognitive reassurance. Okay, that now I've figured it out, or that makes sense to me.
Yeah, awesome. Luke, that was great. Thank you so much for your time and discussing all these cases, giving practical examples. I think that helps a lot to visualize and, give us some tips. So I appreciate your time and looking forward to, you have a new book coming at some point, right?
Yes, still in the works. But, we've got a lot of the Noi Group books and things that I still use for the athletes, but I am working on one specifically for athletes, but it's TBD. It takes some time, but it's interesting. Working with the athletes is giving me fuel for it, so it's good. They're my muse. So.
You've been busy. Paper, NBA paper, books. And
it's good to keep busy.
all kinds of things. That's awesome. Look, if people want to find you, is there any way that they can find you?
Yeah, best way is to go through the Noi Group website. You can also email me, Luke at noigroup.com. I'm usually responsive, but if you can't get directly through the email, the HQ, www.noigroup.com. Any questions, they always get to me, and I do get back as best I can. So,
awesome. Thank you so much, Luke.
Thank you, Mariana. All the very best. Great to talk to you again.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.